Dear students, I am Dr. Srinivas Goli. I am an assistant professor of population studies in Jawaharlal Nehru University. Under UGC MHRD E-Pathashala program, we are dealing with a paper on population structure and characteristics. Under this paper, today I am going to tell you about module number 38 on women and girl child health. In all my previous modules under this paper, we dealt about patriarchy, matriarchy, feminism, theories of feminism, and gender-based discrimination and subordination. All these cultural and social systems will affect women adversely in the spheres of health, education, and economic status. Therefore, it is important to learn what is the effect of this socio-cultural system on women and girl child health. With this, the learning objectives of the module are to know roots of gender inequalities, what are the social systems which is causing the gender inequalities, especially in terms of health. To learn measuring indices of gender inequalities in health, to study different forms of gender inequalities in health, to understand the relationship between gender inequalities and subordination of women and its effect on health, to understand the scenarios of different types of gender inequalities in health. As I said, the major methodology for understanding the effect of different social systems like patriarchy and gender-based discrimination on health was operated through the various social institutions like economic status, religious status, and caste affiliation of the household. And when they interact with the gender, the woman becomes double disadvantaged. So therefore, any study on women and child health must be looked into with an intersection approach. How women becomes more disadvantaged when the health status interaction with the health, when health status interacted with caste, social system, and religion. This framework is basically show you how the different social constructs are related to health outcomes and what are the intermediate pathways through which these social constructs operates. If you look at on the right side, we have socially constructed differences, that is basically gender roles, gender rights, and responsibilities. These affects the women's access to power, access to resources, and the value and self-worth and entitlement, which influences the women empowerment and which again affect on their needs, vulnerabilities, burdens, and consequences for their health, access to health care, and quality of health care, which automatically affects which consequently affects health status and their outcomes. Apart from the social constructs, the scholars also shows that the biological determinant like sex and physiological differences can also affect the health status of the women and girls, specifically genetical susceptibilities, immunities, and resistance. The special physiological makeup of women make them vulnerable to contact with the illness and disease. But however, the major influence is from the social constructed differences, because the biological disadvantage is hard to remove, but the social disadvantage we can remove with appropriate policies. Therefore, this framework helps to understand the relationship between gender and health and how they affect the women and girls' health outcomes. If you look at different concepts and measures related to women and girls' child health, in this module we will look at following concepts and measures. First, levels of gender differentials in health and mortality in India and states. We look at some kind of empirical evidence, what the existing data sources and information is showing us in terms of gender differentials in health status, especially related to women and girl child health. Also, we look at women-specific health issues, which is specifically related to women based on their physiological issues or different reproductive functions, how this is susceptible to or which is vulnerable to these kind of health issues. We also see the pathways of how the excess female child mortality or maternal mortality is taking place in India, and ways to improve it, and what are the need for gendered health policy and gendered health budget to overcome the problems related to women and girl child health in India. Any study on women and girl child health must be looked into a life course perspective. The important life course events and risk related to health at a different point of life course must be studied. Here in this particular chart, you see a life chart which varying from the 0 to 100 years of age, where we have divided entire life course into 4 different groups: childhood phase, adolescent phase, youth phase, and old age. And the problems related to this, particularly the health problems related to these different phases, are different. So now I am going to show you some of the important indicators. There are numerous health problems related to women and girl health or gender and health, but we are looking into some of the key indicators through which we can measure the gender disparities or gender inequalities in health, and especially related to women and girl child health problems. This is especially if the measure belong to childhood phase of the life, which we call child mortality, and especially in this particular indicator we often seen a phenomena called excess female child mortality. In this excess female child mortality, where we observe more number of female child deaths compared to their counterpart males. So generally WHO measures, World Health Organization measures child mortality as deaths of children aged 5 or less years. Then what about the stillbirth and fetal death? Do we count them in child mortality? No, we don't count them in child mortality, because child mortality is the death after the live birth, whereas stillbirth or fetal deaths are counted as death of the fetus before the birth. So we don't count them in the child mortality. The second important indicator, which is at the adult age of the life course, where women go through a specific process called reproductive process, where she has the risk of death due to childbirth and pregnancy. So pregnancy related deaths or deaths related to pregnancy and childbirth are one of the important indicator of women and girl child health. So we measure, WHO measures, World Health Organization measures maternal mortality as follows. Maternal death is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related to or aggravated by pregnancy or its management, but not from accidental or incidental causes. Recently, due to the data issues related to this particular indicator, people also measuring this indicator through another definition. That is, the pregnancy related death is defined as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of cause of death. So this is the change from the old definition. Another important indicator of measuring gender inequalities in health is the difference in the life expectancy of males and females. Life expectancy at birth especially is an overall indicator of health. It is a summary measure of health which considers entire duration of life course. World Health Organization defines life expectancy at birth as the average number of years that a newborn could expect to live if he or she were to pass through life subject to the specific mortality rates of a given period. So, the difference in life expectancy at birth is always considered as the difference between life expectancy of birth between male and female is being considered as the indicator of gender differences in health. So now if you look at the gender differentials in health across these three key indicators by using the latest available information from the National Family Health Survey or sample registration system, we can assess especially what is the situation of gender differentials in health in India and across its states, and we can also assess the condition of women and child health. So let's look at the evidence for the condition of women's health status and gender differentials in health status. This particular table shows the male-female differences in child mortality across the 3 rounds of National Family Health Survey and across the states. If you look at the first year, that is 1990 to 93, which we considered here, across the states except Kerala and Tamil Nadu, we have an excess female child mortality among all the states, and it was high in Haryana, Uttar Pradesh, Punjab, Rajasthan and Gujarat and West Bengal. India as a whole also have 12.6 deaths per 1000 live birth excess in females compared to the males. Then if you look at the latest year, that is 2005-06, although the NFHS 4 data is also come out, but we do not have figures for infant mortality yet now. Now if you look at this, although the difference excess female child mortality has been declining, but is still considerably high, it is still substantially high in Haryana, Bihar, Uttar Pradesh and Gujarat. Surprisingly, even those states which have favorable to female in terms of infant mortality or child survival, like Kerala and Tamil Nadu, which turned around and showed excess female child mortality in 2005-06. That shows that though those states where high excess female child mortality is declining, but among those states where female are at advantage stage, there the female becoming disadvantaged stage in the recent times. This is something is a serious issue we need to be considered. This line of equity plot with scatter of scattering of states around that in terms of under 5 mortality distributed across the male and female in x-axis and y-axis shows that there are a number of states where the female child mortality is excess, and there are very few states where falling to line of equity. Similarly, if you look at the neonatal mortality, this across the different social groups or across the different economic groups, we find the similar relationship. Although the difference is less in the lowest and highest quintiles, but everywhere we see excess female child mortality compared to males. The similar results can also be observed in the postnatal mortality. In the postnatal mortality, across the economic groups, everywhere we see the excess female child mortality compared to male. Even the similar relationship is also observed in the child mortality. The plots of child mortality by the economic groups for male and female indicates that especially in the lower economic quintiles, the gap between male and female in terms of child mortality is very high. There is huge excess female child mortality in lower socioeconomic groups, though this gap is slightly reducing when we move to higher socioeconomic groups. This overall indicates that girl child health in the early stage of life is worse compared to their male counterparts. Our girl child is more disadvantaged in terms of health compared to their male counterparts. Here we look at some of the process indicators like healthcare indicators which shows the discrimination or disadvantaged stages of women in terms of access to the healthcare, especially disadvantaged stages of girl child in terms of access to healthcare. This particular chart shows the trends in percentage of female and male children aged 12 to 23 months who are fully immunized across the 3 rounds of National Family Health Survey. Across all the rounds, we see the immunization levels are better among the male children compared to female children. This again shows the higher discrimination for female children in terms of access to health compared to male in households. As I said, so whenever we are looking at the girl child health, we need to look at the both between and within inequalities. That is important because between inequalities are between the male and female children, but within inequalities within the male, within the female, they are across the socioeconomic groups. That is need to be examined along with the levels and trends. If you look at this particular concept in terms of empirical analysis, we find the overall inequality between male and female in terms of health are decomposed, and we found that the within inequality in the male and female is contributing in a greater proportion to the overall inequality compared to the between group inequality. That means within the female children, they are the group of children who are disadvantaged more because of their socioeconomic status. So the girl children across the families is treated differently rather than uniformly. So the gender discrimination is not uniform across the socioeconomic groups. Here we are again proving the point that the intersection approach is very important for dealing the girl child health issues. Then if you come to the maternal mortality, which is the discrimination, which is an outcome of a discrimination or disadvantaged status of women at adult ages, when they have undergoing a special physiological function or reproductive function which as a consequence of their natural biological process. If you look at the levels of maternal mortality ratio by regions, we see there is a considerable progress we achieved in terms of reducing the discrimination and disadvantaged status of women over the period. Thus, we have able to reduce the maternal mortality ratio across all regions. But still, if you compare India's maternal mortality ratio with any other countries, we have a more disadvantaged stage. Particularly within India, if you look at the different regions, particularly the EAG states, Empowered Action Group state, which are earlier called as the Bimaru states, which contributes 60% of maternal death to the total country deaths. That means in these states, actually, the women is more in disadvantaged stage and discriminated more. So as I told, if you compare India with other countries, we have around 167 maternal death per 1 lakh live births. We have around 167 maternal death per 1 lakh live births, whereas even our neighboring countries like Sri Lanka just have 29 maternal death per 1 lakh live birth. And Sweden has as low as 4 maternal death per 1 lakh live birth. So compared to these countries, we are much disadvantaged. Women in India is much disadvantaged condition, or are discriminated more. Even if you look at the other type of health indicator like child nutrition across the male, female, or across the boys and girls, we observe that the female are more undernourished or stunted or facing underweight compared to their male counterparts across all age groups in the childhood, from 0 months to the 59 months, or that is less than 6 years of children if we consider. The same thing which we can also observe in the adolescent age groups, where BMI of female is much worse. Female are facing anemia problem, they are underweight, or they are facing the problem of underweight compared to their male counterparts. Especially anemia in India is as high as 50% in the non-pregnant women. It is in pregnant women, it is even more worse in pregnant and lactating women. Even in the, if you look at these indicators by women's status indicators, so once you cross-tabulate these health indicators by the women's status, what we observe is wherever the women has a better autonomy, their children, particularly the girl children, are at the advantageous stage. For example, if you look at this chart, we find that the female immunization levels are much better compared to in general condition if the women have a certain freedom, particularly mothers have a freedom to take decision alone. So this indicates that wherever the women's status is better, we have a better child immunization levels for both male and female discrimination is less in terms of immunization. And even if you look at the menstruation, menstrual hygiene and using of sanitary pads, this is also one of the important natural process which happens to the girls, children specifically. Here also, if you look at that, the condition is very pathetic in India. If you look at the figures, the number of women using sanitary napkin during menstruation, in particularly in the regions of central, east and all, it's just 6%, 7% women using sanitary napkin. This means how children are discriminated in India. Even if you look at the attitude about social norms and distress during menstruation, there are many women who feel impure, isolated and depressed, irritable during their natural cycles. That means it's a simple natural process also creating a kind of social problem and stigmatic problem to the girl children in India. So how do we explain these gender differences? We can explain these gender differences to two theoretical perspectives. One is women and girl children have a differential exposure theory. And the second one is women and girl children also have a differential vulnerability theory. So they are more exposed to certain risks and they are also more vulnerable. So because of these two, they have more health issues compared to men. And this exposure and vulnerability is more as a consequence of this social system rather than the biological disadvantage. That we need to be remembered. If you look at this particular two concepts, most of them are coming out of the existing social setup, that is patriarchal economic structure, perceived cultural norms, that is a religious and caste-based institution norms, perceived economic utility of boys over the girls.